to the dish properly.
Nitin, anything to add on that?
I entirely agree with what both Himanshu and Barjot have mentioned. Only one thing I would want to add is it's also important to realize what is the pre-LASIK corneal curvature. Because in myopia, we are going to flatten the cornea. If we already have a flat cornea, even in a small degree of myopia, we can't flatten the cornea beyond, say, a 35 diopter. Again, in a hypermetropia, we can't steepen the cornea beyond 53 diopters. So doing that would induce extra aberrations, which we don't want to. So in addition to the pachymetry, in addition to the pupillometry, it's important to also know what is the corneal curvature and then decide. In general, every diopter of correction, refractive correction, would change the corneal curvature by about 0.7 diopters. So that is a general formula to follow.
Yeah,
so if
I think
correcting
this covers, all the points. Swapnesh, I think this is covered. Swapnesh?
I think he's on mute.
Swapnesh is muted.
I think he's trying to start his.
Yeah, back. He's back.
Swapnesh?
Yes, yes. So
Yeah,
what
we
is-
are done with that.
Yes,
Yeah.
yes. What is your consideration for the pupil size when you decide in a pre-op workup? How important is that, and how do we go about it?
So, Barjot, could you start off?
At the onset, I'm working a little differently in that I do TopoLink for all my cases. So I, by default, see the pupil size for all my cases, measured on the TopoLink setup. I use the Zeiss system. Again, you have to correlate what we are doing in the way of ablation with the pupil size. Now our lasers, by and large, I don't know, but I think my laser goes up to 6.57 optical zone. I don't know about the other machines. They probably do more. I remember one old machine used to go to 9 millimeters optical zone, the autologous or autonomous system. But if I have a pupil around 7-ish, I'm not happy to do the case, or I will call the patient back into my consulting because I do the TopoLink readings just before the surgery. I'll call them back into the consulting and say, you're going to have night problems, do you drive a lot? And all that sort of stuff. And if they're the type whose night activity is important, I won't do the case.
So, Barjot, are you, is your TopoLink giving you a mesopic pupil or a photopic pupil?
No. In the dark, actually.
Okay. So, you're taking that as your cutoff.
Yes.
Yeah.
Because it's no big deal if you do it in lit conditions,
Yeah.
So the room is completely dark.
So, Himanshu, what is your pupil? Hello?
Yeah. I'm unmuting him.
Yeah, I agree with Barjot. The maximum problem that we have with LASIK is night driving problems and refraction of light. So the bigger the optic zone that we manage to keep, all problems of aberrations arise because of the pupil. And that's why Amar's small pupil pupilloplasty became so popular with everything. So having said that, ultimately, if your pupil is big, you have to restrict yourself the amount that you can correct. So if it's a smaller pupil, and which unfortunately is vice versa, the more myopic you are, the bigger the pupil these people will have. And so if you do a small optic zone, 5.5 in a -7, we're going to be in trouble.
How do you get your pupil size, Himanshu?
Yeah, as he said, you have the pupillometer with which you can.
Oh, you get, which he's got another machine. Which on your machine, how do you get it?
Yes. So with switching off the light and then taking the size of the pupil.
On your topo?
Yes, on my Cirrus machine.
Okay, fine. I think
I would just generalize one thing. The most safe in 90% of cases that I would say 6.5 kind of optic zone overall helps you to reduce most of your problems. The more you economize after that and go to 6, 5.5, all problems start there.
Unless you've told the patient specifically and you've put that in your consent, with these dodgy patients, I give a very kadak consent in addition to my normal consent. And I tell them,
That's
you will see halos, you will have difficulty driving, you may not be able to drive, and if you agree to that, then
then only.
yeah.
Yeah, that's a good thing. So Swapnish, the next.
Yeah. So what is the cut? Yes, sir.
To see whether if you are the contact lens user, most of your contact lenses have an optical zone of 6.5 millimeters. So in case the patient did not have glare for night driving with contact lenses, it's unlikely that he's going to have a glare. This is even if you don't do a pupillometry, though I'm not recommending that you shouldn't do a pupillometry. Pupillometry has its definite importance, but a general rule to follow that if a contact lens user was glare free while night driving, he usually should be a good candidate for a LASIK with a 6.5 millimeter optical.
That's a lovely point, Nitin.
Very good point.
So next question.
Swapnish?
Yeah, next point is what is the cutoff K and pachymetry reading, in the sense what are the readings when there are red flags, when the surgeon should be alerted?
I think K reading already Nitin covered in his, we can't go below 35 for while after treatment of myopia, and more than 50, 52 for hyperopia. So let's take the pachymetry part. Raja, what is your cutoff of pachymetry for LASIK or PRK, and do you use it to differentiate, which procedure or whatever?
See, if I can't do LASIK, and as I said, pachymetry is relative to what correction I want to do and how much my laser ablates per diopter. And having done those calculations, I see whether the pachymetry in question is appropriate, and we've gone through that. The K readings, I would take rough guide. The lower K to be 39, 40-ish, 38, 39. And the upper K may be about close to 39, close to 48, 49, thereabouts. You must understand with the higher Ks, you have to use a different, I'm talking about LASIK, not femto LASIK. With the higher Ks, you use a different type of ring, which is specific to these high steep corneas. So with that, you can go up to 49, even 50.
Okay. Himanshu, what would you?
Yeah, I mean, there is no ambiguity in your mind. As you said, 34, 49, that would be the answer. So maximum correction after myopia would be maximum going up to 35, 34 if you have to push it up. But 35, 49, 50 maximum. That's the way. Right?
Nitin?
Agree with that. Totally agree with that. Only thing is, as far as pachymetry, like Barjot said, it's a play of all the other factors, that the amount of correction which you're going to do, the flap thickness and things. So that's all. But I would like the consensus. Let's make a consensus in the house. What does the house feel? Below what you would not take a patient for refractive surgery, A, and B, below what you would not do a LASIK. So if we can have a consensus. So for me, it's below 280, no corneal refractive procedure. Between 290 to 280, yes, I would think of a PRK. Less than, and below 295, considering that above 295, yes, a LASIK, yes, but considering the refractive error. Obviously, if the refractive error is too high, I wouldn't go for it.
You're
talking about your residual. You're talking about your residual
stromal bed that you're talking about, Nitin.
You're talking about the bed, Nitin?
Yeah, I'm talking about the RSB. I'm talking about the RSB.
Any comments, Himanshu and
500 LASIK, frankly, and 480 for PRK, if I had to get onto that.
Berger?
Yeah, I think that's pretty sensible, Himanshu.
Yeah. Okay, Swapnish, we can go to the next one.
Yeah, so now that we have newer machines which image the posterior float also, what is the maximum posterior float readings permissible on a pentacam or a OpScan or a CS?
I think this is just a factual. We don't have to take four opinions. So OpScan, the value is about 50 microns of the posterior elevation, and pentacam at the apex is about 3 to 4 microns, and with a standard deviation it comes to about 18 microns. So I think there's no
Sure.
need to take
Yes.
4 things on this. Yeah.
Yes. Now coming to the actual surgery, how to deal with when we are faced with a small palpebral aperture in a patient? What are the precautions we can take, or what are the tips?
Nitin? Hello?
Yeah, basically you need to use a good speculum, a good rigid speculum. Now, the problem which occurs in these cases is that when you try to open the speculum, the patient is uncomfortable. So what we do normally is just before applying the ring with the microkeratome, I would open up the speculum a little bit more. At the same time, you get certain special rings which are available for very small eyes. Moria makes rings which are smaller diameter rings, or the rings which are especially what they sell in China. One could think of sourcing them. But in case of a very small palpebral fissure, a femto-LASIK would probably be the best reply, because the femto-LASIK, the cone is the patient interface, and the cone is much smaller than in a microkeratome LASIK.
Anything to add, Bajar?
Yeah, you could do now only for the experienced surgeons, do the LASIK without a speculum.
Right, yes, that's true.
One
I
more
think-
thing, we could change if it's a M2 keratome. You could keep it temporal. Basically you could change. If it was the previous microkeratome, we had a superior flap. You could keep a
yes.
temporal flap.
So I think this, sorry, Bajar. Yeah, so I think this covers this point, Swapnesh.
Yes. Then the next common thing is for the beginners, how to avoid the suction loss, and what are the markers of knowing that you have got a suction loss.
So I think this also in a modern keratome, if you just follow the 2-3 points that come up, when you attach the suction ring, the pupil starts dilating, the patient starts to lose the vision, and some keratomes will give you a beep that your pressure is achieved. On the monitor, they'll give you a level, like Moria says, below 200. You can go ahead and with the keratometry, and you can move the eye if it is firmly attached. I think this is main things. Anything to add, Nitin?
The most important thing, suction loss, is the patient shouldn't be squeezing. So one needs to keep talking to the patient, tell him not to squeeze. Because if he squeezes, even with the best of the suction, you can break the suction. Thing number 2 is keep your ears open. It's very important to keep your ears open for that little bit of hissing sound which comes when there's a suction loss. See to it that at that time, there is no other sound around. Because if you miss that sound and you advance a microkeratome, you're bound to have a complication with your flap. So keep your ears open. Moment you hear that hissing sound where there's a suction loss, stop and then reapply the suction.
Yeah. Himanshu, anything? Bajar?
Yeah. Bajar, go ahead. I'll see you later.
Also be well aware, once you've made that ridge in the conjunctiva stroke sclera with your suction, and you've then, for whatever reason, stop the suction and put the ring back on again, the eye will go right back into that groove. You're not going to make another groove. The way to get around this is do the case 15 minutes later, when that suction groove has gone away. Otherwise, you're going to go back.
No, so Bajar, are you saying, suppose you have a suction loss and the flap has been created?
Oh, no,
say
no.
50%, no.
No, that is a different issue.
Okay, you're saying just
now,
before the start.
About when Nitin's alarms went off. He heard the little residual hissing sound. And he said,
before starting the flap.
Yeah, let me put the thing back on again. In most cases, it will go back on again.
Yeah.
But beware that in the naughty eyes, it will go right back into the same trench, so to speak, on the episclera, and you might have caused a little chemosis, and there's even more chance of you getting pseudosuction.
Yeah. Himanshu, you were saying something?
Yeah. I mean, actually, every time suction starts and your Moria or whichever goes, you got to take God's name. By the time you react, midway suction loss is the worst thing, even with a femtosecond. and you've seen multiple videos, each one of us says that in those 30 seconds, nothing happens. And it's a deadly scenario. You can't do anything. It's all very nice and dandy to say, I can do this, I can do that, till your action has started. Once it has started and the bullet is out of the barrel, it's very difficult to control after that. So it depends what time is it that you lost your suction. And very careful with suction, take your time. And as Burjot said, do the other eye and come back to this eye.
Also, something that has fallen out of use over the decades is the use of applanation when you got your pressure. You know, it was my cardinal rule for 15, 20 odd years to do it routinely. But even I've fallen by the wayside, so to speak. And I sort of rely on feel rather than that hard and fast applanation, which you in the early days saved you from disaster.
So I think this covers this well, Swapnesh.
Yes. So next we move on to the flap complications. Can each one of the panelists tell how to manage a free flap, then an incomplete flap, and then a buttonhole flap?
So I think let's give one of these to each.
Yes.
Baja, if you take the free flap and maybe Nitin take the next one, incomplete flap, in that way. So Baja, would you like to start with the free flap?
Yeah, sure. Firstly, free flaps are super rare, but if and when they do happen, they're super frightening. But I must emphasize that you shouldn't be frightened because they're surprisingly easy to handle. And the question arises here, once you've got your free flap, what do you do with the guy? Do you panic and remove him out and put him in some petri dish and put saline on it? Don't do anything. Just leave him in the keratome. Go ahead and, I mean, if you got a sort of a goodish bed, you know, not if you got a ragged bed, but go ahead and do your laser. Then gently pull him out of the keratome. The important thing here to realize is the side that is facing you when you invert your keratome is the stromal side, and bring that down into the bed and then just float it into place. It's not an issue.
Yeah, so I think the only thing I would like to add is this is the one time when the marking of the flap would have been extremely useful. Though as Baja was talking about the tonometer, which went by the wayside, and most surgeons have given up marking of the cornea. Because when this free cap is put back, you can get bad astigmatism if the orientation is not proper in spite of being a good fit, you know. And
so the timing of marking,
sorry,
when to mark is also important.
Marking just before taking the flap, you know. Okay, Nitin, would you take incomplete flap?
Yeah. With the incomplete flap, what is most important is to know how much the flap is cut. If the flap has cut just short of the optic zone which you're making, abort the procedure. But if it has bypassed the optic zone, one can go ahead and do the LASIK. But what is most important in these cases is to protect the hinge. You need to use your Merocil sponge to retract the hinge in such a way that you do not ablate the hinge. Otherwise, you'll again have the hinge totally cut off by the excimer laser, and you'll have a sort of a free flap over there.
You will. Sorry.
Yeah,
go ahead.
Point is in a free flap, in a incomplete flap, see to it that the optic zone is totally covered, totally opened up. If your optic zone is not opened up, do not do a LASIK in these cases.
Yeah. Baja, you wanted to add something?
Yeah. Now, this was a problem in the days when we had what was called the ACS, automatic corneal shaper. And to that end, I devised something called a LASIK shield, which I used to use again for every case. So there was no laser radiation that ever fell on the hinge. I would beg to differ, Nitin. If I got anything short of a perfect flap, I wouldn't do the case, full stop. I'd come back later and What's the big deal? Yeah, to lift up the flap and do it later, or make a new flap or whatever. But invariably, invariably in these cases, Nitin, your patient's going to be pissed off because you're going to put something on the hinge. You're going to cause a double refraction there on the hinge and in the bed. And it will cause a lot of problems in the vision.
I think so. We have two views on this. Himanshu, can you take the buttonhole, please?
Yes, I'll take the buttonhole. I just wanted to add that I would agree with Berger. I would abort the case. And I'll give you one more example of a partial flap with a femto. It's 100 micron, 110 micron. I would abort it, and or if the OBL is out, I can go ahead with a microkeratome blade with a 140. I can do that over there. That's just the addition that I wanted to say on the, if I want to do it in the same sitting, but ideally abort. Having said, the buttonhole with respect to the femto is out of question now. Majority cases converted into that. With the new M2 microkeratome which we have, I haven't seen a buttonhole. On a steep cornea, we used to see abort, period. Put back the cornea, abort. Nothing further.
I think this covers this, Swapnesh, very well.
Sir, consequently, I'll just take few comments on the same topic. Hello.
Nitin,
Yeah.
just let's take the comments first.
Yeah.
Swapnesh.
Praveen Punamia has commented that unequal marking for the free flap is important. And Dr. Siddharth Mehta has asked a question, is free flap possible in femto also?
I think let Berger take that.
I did. He cut out. I couldn't hear.
Dr. Siddharth Mehta has asked, is free flap possible in femto?
I don't know, but short of a free flap, I've got every bloody complication possible with a femto. Let me tell you that. I have in 25 years of doing LASIK, I have never seen more complications than with my bloody femto.
I second that.
Okay, then what is any other,
Swapnesh,
anything else?
No, next question.
Okay, go ahead.
If it is in the books, just for if you guys are listening to this,
yes.
If it is in the books, it's going to happen to you. If you are going to operate on cases, you're going to get what everybody has got. Period. So it was not a laughter of sadism for Berger, but it was everybody has gone through that. Am I right, Berger?
I don't know about everybody, but I can put both hands up and say I've gone through it.
Okay, let's go to the next one. We are a little time bound.
Yes.
Swapnesh.
Yeah, how to manage post-op debris which we see under the flap?
I think this is let's just
and also maybe we can include maybe DLK guidelines for diagnosis and treatment.
No. That we'll take it immediately. This we'll leave it as most post-op debris, if it is insignificant, mild, not in the visual axis, not causing a reaction or this, can be done. Olden days, if you are not free, you have lint in the atmosphere. Nowadays, with everything being standardized, I think this is not much of a issue. You can go to DLK guidelines for diagnosis and treatment.
Yes.
Okay.
Yes.
Berger, the DLK diagnosis.
I presume you mean SANS, right?
Yeah, SANS.
Yeah. You will see them off and on, more off than on, hopefully. And they will come in crops. They won't usually be an sort of isolated thing, which you'll then see a year from now. If they are in the periphery, as they usually are when they start, evaluate them carefully. Watch if they are coming towards the center. Watch if they've started to clump. This will usually happen on day 3-ish. If they if the WBCs start clumping, immediately wash it. And with impunity, do not be an ostrich and put your head in the sand and saying it may go tomorrow. That tomorrow is too late. It will change in 24 hours between something you can salvage and something you cannot.
Yeah. Anything to add, Himanshu?
No, fortunately, it's become a little rare now. We have seen it way back. And with the femto, I haven't seen one. But as better to intervene early than not intervene, I agree with Berger on that.
I think we have covered.
Wishful
Nitin,
thinking
anything
doesn't
extra? Or?
That's all. Nothing specific.
Okay. Swapnesh, that is done. Swapnesh?
Post-operative medications of choice from each of them, and how long duration?
Okay. Himanshu, what is your?
Just mild painkiller orally, no oral antibiotics. Locally, steroid antibiotics, separate, not a combination, and lubricating eye drops.
How long?
3 weeks. Antibiotics for 10 days. Steroids would be for 3 weeks.
Okay.
And lubricating would be 6 weeks.
Nitin?
Almost the same. A soft steroid for about 3 weeks, antibiotic for a week or so, and lubricants for at least 3 to 4 months.
Baja?
I give Vigadexa for a week and Cystine for about 2 months.
Okay. That's okay. Swapnesh, that's done.
Yeah. Okay. When to suspect a raised IOP? What are the signs and what is the management?
Okay, so basically this is, what is called as pressure-induced stromal keratitis. It's a very good differential diagnosis, always mentioned in the books. It's not very common. I've seen one, but it occurs much later than DLK, few weeks later, and you stop the steroids and it responds. The main thing is you have to suspect it. If you suspect it, you'll take the pressure, and the pressure is invariably high. There's no management. You just stop the steroids, everything comes back to normal. Probably the same as steroid responders and things like that. Himanshu, anything to add on this?
No, not really. It's the worst nightmare. You want to differentiate between DLK and this. DLK would be earlier in the phase, increased IOP, steamy cornea, pain. And the worst is the PRK patients, where you have to continue steroids for a longer period of time, and especially if they have infiltrates and your cornea is hazy and they turn out to be steroid responders, is a situation which I would say.
Nitin, anything to add to this?
An anterior segment OCT, a corneal OCT helps in these cases,
Yes,
because you
see
can
the fluid.
detect the fluid line.
Yeah.
So, and in these cases where you have the fluid line, it's very important to note that your pressure which you measure may actually be low.
Yeah.
So that is a time where you may get misguided with the whole thing about how to go ahead with the treatment.
Yeah.
Increasing steroids, thinking that it is DLK, will worsen the case. So one has to be careful about this.
I think this has covered it. Baja, anything to add?
No, absolutely. And
Okay.
when you measure the pressure will invariably be low, because
Yes.
you're measuring the fluid pressure in the interface. What I used to do in the old, and I've seen about 5-7 of these, and they only occur because you use steroids for a prolonged period of time. If you use it for a week, 10 days, nothing is going to happen. You're not going to get a responder in such a short time, or if you do, they'll be extremely rare. Also note that you will have Flarex responders too. So be aware of that.
Yeah, good point. Yeah, I think that covers it, Swapnesh.
Yes, sir. So, Dr. Ramesh Shah, sir, has raised his hand. I'm just taking him, I'm unmuting his mic. Are you there, sir? Ramesh Shah, sir?
Yes, sir. Yes, sir.
Yeah, you wanted to make a comment? Hello?
Hello,
Ramesh, sir,
can you hear me?
Yes.
See, this is not regarding this slide, but the previous slide.
Okay.
If you allow me to speak.
Kapoor, sir,
Please, Ramesh.
Yeah.
Hello.
Yeah, Asi, go ahead, please.
See, the one thing probably I emphasize very strictly is the PTA. And that will solve the problem about the thickness, the amount of ablations you do, amount of myopia you correct, or hyperopia. So PTA for me is a very important thing.
What was that again?
About the size
Percentage
of the pupil.
thickness, like we take residual stromal bread, Baja. He's counting percentage thickness.
No, it's percentage tissue ablation,
Tissue
which
ablation.
is basically
Yeah.
a ratio
So
of, it is the, you add the corneal.
Let Ramesh finish, Nitin.
Ratio of the thickness of the flap plus the amount of ablation you do divided by the total thickness of the cornea, which should not be more than 0.4. I keep it 0.38 is the final one. Second thing is the size of the pupil which you are talking about. I select my pupil size, and on my screen I can see on the NIDEC machine I can see the scotopic as well as the photopic pupil on a simulated map, and I decide my zone. Optic zone should not be less than the highest size of the pupil, and the difference between the optical zone and the transition zone should not be less than 2. I can go up to 4.5 optical zone and 6.5 at the higher side. In that machine, I can do that. Regarding the topoling, which Barjor said that, I also do either topoling or OPD scan base, in which I started recently adjusting the spherical aberration in 4.5 millimeter and not 6 millimeter. Because if you see, you don't need this 6.6 millimeter of spherical aberrations, and my number of unhappy patients has reduced drastically. So these are the few changes which I made in last 6 months, and it has given me a very good results.
Thank you, Asi. Thank you for the comments. Swapnesh?
Yeah, next question, sir.
Next. Yeah.
Is how do we evaluate a patient with regression? How we come to the diagnosis, and when is the right time to treat him, and what are the options?
So Himanshu, would you like to start off with this?
Yeah, patient with regression, the worst nightmare that we have. You may have undercorrection because you had a few people. It should not be taken as regression in a few patients if within the first 15 days you've seen that the patient is undercorrected. Your parameters in the OT might have changed because of the humidity, the air conditioning, and or the gas position. That's something very important. Regression should be a phenomena which we would consider only after a few months. And if there is regression, I have to look for ectasia. I would wait for that to happen. If there is no ectasia, then I would take it very clearly that to treat that or not, and when to treat. Being very clear that when I raise the flap, there is always chance of any kind of epithelial intrusion inside. Given a choice not to do that, but if you have to do that, take extra care to remove all the epithelium from the periphery of the flap.
Thank you. Nitin, anything to add?
Yeah, the most important thing in regression is whether to lift the flap or to do a PRK. It all depends upon how much of the refractive error has regressed. In case the refractive error can be corrected by just ablating within the flap. Suppose your flap thickness was say 130 microns and you need to treat only about 16 to 18 microns. It's better to do a trans PRK so that you don't ablate further amount of stroma. You ablate only the flap. So that would be a better option than lifting the flap, because lifting the flap, like Himanshu said, also carries the risk of an epithelial ingrowth.
Right, that's true. Barja, anything to add to this?
No, I have, personally speaking, I have no problem with lifting the flap at all, at any point in time post-surgery, even years later. My technique is such that I always run my spatula under the flap as a final chakkar around the boundary to see that there are no tags that have gone in or inverted into the stroma. And I put a contact lens on for a day, and I've really not had a problem. I can't remember when I last had a problem. So I have no issue with lifting the flap, or cutting a new flap or whatever. I don't have experience of doing a PRK on a LASIK, or if I've done it, I've forgotten about it.
Right.
But your question is,
I think this,
Sorry, Shashi.
No, Himanshu, what?
But your question is regression and undercorrection.
No, as you said, in the initial phase, it's undercorrection. Regression will come much later. Yeah. So Swapnesh, I think this is covered.
Yes. So now going on to epithelial ingrowth, what are the classic signs, and when do we need to actually manage it, and when can we leave it?
I think this we'll give it only to Barja, because there's so many new questions have come up. We are running short. We'll run short of time. Yes. Barja, could you take this epithelial ingrowth, please?
Epithelial ingrowth you will see close on 8 weeks or so after the surgery as very evident. Before that, you may see what I call as tide marks, like a receding tide around the margin of the flap. Now, that could occur if your keratomotor is not working too well, and in the days gone by when people would reuse blades. So those days, I think, are long past us. So if we see an ingrowth, it will be sort of mid post-op in months rather than days or weeks. Most ingrowths will be benign, but there are others which are nasty and they progress fast. You can monitor the epithelial ingrowth two ways nowadays with OCT, but in days gone by with your topography, when you would see progressive topographical changes occur over time.
Yeah.
I would.
And what about the management? You would lift the flap?
Yeah, I would treat an epithelial ingrowth, A, if it's affecting vision, or B, if it's coming close to the dilated, the mesopic pupil size, because that will affect the vision. The flap melts and all are not, we are not going to see that anymore. But it's very important in the procedure per se of removing epithelial cells to remove them both from the bed as well as from the flap.
Would you recommend using alcohol or something?
No. Yeah.
Okay.
A good old 15 number Bart Parker knife, fixate the flap properly with a sponge so that you don't rip off the hinge, and scrape your blade across the bed as well as the stromal side of the flap, and go right up to the edge of the flap, because that is where the epithelium has come in from.
Okay, thank you. I think that was well covered. Swapnish, what is next?
Make a point.
Nitin, yeah.
I would recommend everyone to go to YouTube and see Berger's film on epithelial ingrowths. It's probably one of the best films which I ever seen of how to manage epithelial ingrowth. It's available on YouTube. Berger has posted it.
Post the link later. Yeah. Swapnish, that's done.
I've forgotten that.
Age catching up, Berger. Age catching up.
Yeah, there is a specific way to do it.
So next question is the PRK is now becoming gradually coming back in fashion than the earlier days. Now LASIK versus PRK in present scenario. What is your take on that, Kapoor sir? Yeah, I know you do both equal high numbers.
Yeah. Yes. So I don't do many PRKs now, but about 300-400 eyes a year. But most of them are the occupation or profession related, which they are joining the army, navy, which also, if it's Mumbai police, the Mumbai police allows LASIK, but the Indian Navy, they don't allow, for example, a LASIK PRK. PRK, this question is very well in the whole of Europe also. It's become the most frequently performed procedure in many parts of India. For example, as you are a retina surgeon, and how Shankar Netale dictates a lot of the, trends. And in cornea and refractive, L.V. Prasad dictates the trends. And L.V. Prasad has become a huge proponent of PRK, extremely huge. So if you go to Hyderabad, Andhra Pradesh, neighboring, and where their fellows have settled, today there's a huge interest in PRK. Let's take this one by one. Himanshu, do you do PRK, and what's your take on it?
Yes, PRK, I've burnt my fingers. It's nice surgery, very simple, doesn't have sophistication of a microkeratome, and or having a femto saves you a lot of money. Having said that, one reaction after 100 cases or 200 cases where you get infiltrates, and if the patient is in trouble, you have a lot of reaction and delayed healing time. Today is the instant world, 2 minutes Maggie, a pizza, burger, if Amazon delivery doesn't happen in 24 hours. And we have trained our patients in the past 20 years thinking that kal office mein ja sakta hai. Unfortunately, to tell and explain to them is a very important criteria that it's going to be painful, it's going to take time. Yes, it is good for you, but it'll take time. Quite a few of them don't really want to do that.
Fine. Even these points of visual recovery is late, pain. Nitin, anything to add on that?
The three things which people differ for PRK are the pain, the haze, and the regression. Pain can be controlled basically with topical NSAIDs and even probably an Acuvale soap sponge like Narayan Netralay has proposed. the haze part of it can be controlled. Haze, if one understands, is haze is due to an inflammation. All the inflammatory reasons for the haze can be taken care of. Preoperatively itself, we need to see that there is no MGD, there are no allergic reactions.
No. Nitin. First, do you do PRK or you don't do PRK?
Yes, I do PRK. I
What
have started.
percentage?
Well, right now it's about 20% of my patients who do PRK, specifically like you mentioned, for those patients in which a flap would not be safe, a professional boxer, certain people who want to join the army immediately or the Air Force for that matter. These are the cases, and now with trans PRK, the rate of PRK in my cases are increasing because the complications which were there with the alcohol removal of the epithelium or with the manual removal of epithelium is much lesser as when you do it with the trans PRK.
Okay, Berger?
I do PRK occasionally, but there are only two people here who have seen PRK of the old days. That's you and me.
That's true. Berger, after that old, I stopped for a long time. I've started again.
PRK today is a completely different beast than it used to be decades ago. I have had to give patients, pain-killing drugs like Tramadol and injections and stuff like that to control the pain. Today, in my experience, PRK is almost as painless as LASIK. If you're following it up with contact lenses, I remove my contact lenses 5 days post-op or when the epithelium has formed over totally. And again, the rate of re-epithelialization is so variable. I've had epithelium reforming in 2 days. And I've removed the contact lens, giving it breathing space. I've removed the contact lens a day later. And I used mitomycin C. I'm seeing a question here. I use mitomycin C for all my cases.
Berger, how much time?
20 seconds.
Not more. It doesn't depend on the refractive error.
I've been doing 20 seconds blindly, and I can't.
Okay, and do you have a rule that you do PRK for a upper limit of myopia, anything?
No, not really. And where do you see these? At least I don't see these humongous myopias who are coming in for refractive error. And again, I don't do the ICLs, so that part of the population has gone from my practice.
Yeah. Okay, so I think Swapnish, that covers this. LASIK versus PRK. What's next?
LASIK extra, is it worth the effort or not?
What on earth is LASIK extra?
LASIK extra means you do the collagen cross-linking at the same time as LASIK because you think it's a suspicious topo and you are really not sure in the first place whether you, I think in that, this first thing questions that you want to do a case where you're not sure you want to do it. So, I don't know. Berger, any comments on this?
No, boss. No comments.
Himanshu?
No.
Okay. Nitin, anything?
If you can't do a LASIK, you can't do a LASIK. Once you cut the
I think that is the general consent that if it's a suspicion and you don't want to do it, then I think that should just decide. Next, Swapnish.
The action is purely your guilt that you're doing it. The extra part is your guilt, or you have the machine.
Correct.
So the next question, how important is the sibling history in LASIK workup? And are there chances that we might miss a small amount from first keratoconus, FFK?
I think this is just a small thing. So basically, we all go on the topography. What this question implies that we should include in the history. Is there any family history of corneal disease, especially ectatic or allergic eye disease? It's a good point, and it should be included in the history. I think let's go to the next one.
So post LASIK ectasia, what is the preferred algorithm for management?
Okay, Nitin, you'd like to start off?
One has to be sure that it is an ectasia. So basically, one has to start from seeing whether there is you should not confuse an ectasia to a regression. So wait for it, see whether it is progressive, see whether the cylindrical refraction is also increasing. At the same time, keep doing at least monthly topographies to see whether the signs of ectasia are present. If it's definitely progressive, if it is a definite ectasia, then one needs to intervene early. One can't wait for an ectasia to progress beyond a particular level and then to treat it. So obviously, corneal collagen cross-linking would be the answer for it. One could combine a corneal collagen cross-linking with other procedures also. Like you could, if there is enough cornea, if there is enough residual stromal bed, one can think of regularizing the bed, regularizing the keratometry with a topo-guided PRK along with a C3R. Or in case the ectasia is not central, you could do an NTAX to centralize the cone and then do a C3R. So in worst cases, obviously with ectasia, then one has to think of even going in for a DALC, and worst cases beyond that would also go, one had to think of a PK.
I think very perfect. You have covered it systematically, all the points. Anything to add, Himanshu?
No, absolutely. You don't want to see it, but if you've seen it, it's not going to be like keratoconus that you have enough time to put it intact. But a topo-guided PRK on just to make the levels good enough and do a CXL together would be a great idea.
Bhaja?
No, nothing more. You covered it totally.
Swapnesh, this is well done.
Yeah. Okay. So, few tips about hyperopic LASIK, patient selection and how to go about it.
Yeah, so hyperopic LASIK, the main thing has always been the regression and the lower amount of, it's not like myopia, you do it up to -8, 10 and all. So these are the two main things. So on these two things, what are the opinions? Bhaja?
I increasingly I'm doing less and less hypermetropic LASIKs. The patients who really complain about it are those people who are in their late 40s, early 50s. And I would do a prelax on them rather than doing a hypermetropic LASIK. The guidelines that I would strictly follow is don't attempt anything beyond +3. Use large optical zones because regression is common, as you mentioned, Shashi.
Yeah.
And I would 100% do a topo-link because the angle kappas here are usually quite nasty.
Yes.
So don't just do a standard old LASIK because you land up in a problem. In days gone by, in the days before the topo link,
Yeah.
I had a special way of intentionally decentering the laser to compensate for that. It was sort of a guesstimate way of doing things, but you wouldn't even dream of doing it today.
Anything to add, Himanshu?
I think on a different note, hypermetropes are the most happy patients. If they start
Yeah.
seeing a few things, they are very, very happy. But what Bhaja is really mentioning is between the age group of 40 and 48, there are these women, 38 and 48, when the latent hypermetropia is evolving. We keep saying that it is regression, but their latent hypermetropia is evolving, that their muscles are getting weaker. But frankly, 48, 50 plus, quite a few of them would decide. I have seen them very happy if you told them that you will need a number later. And I would say I'm not very disheartened by hypermetropia treatment. They do pretty well.
Right. So Nitin, anything to add?
The most happiest patient for hypermetropic LASIK are the ones in which the manifest refraction is the same as the absolute hypermetropia. If there is no latent hypermetropia, these are the happiest patients because then there is no, not regression, but there is no uncovering of the latent hypermetropia. So one needs to see how much of the quantum of the latent hypermetropia. The latent hypermetropia is a higher quantum. Do not take up these patients or try to overcorrect. Try to overcorrect by at least about 25 to 30% of the latent hypermetropia, telling the patient that in the first few months, your vision will not be so clear.
No,
They will still be delighted, Nitin, because you're giving them reading which they never had.
Correct. So,
Correct.
so monovision, I prefer to do a monovision in these kind of people. So even if it regresses in one eye, the other eye is helping them to do a lot of stuff. For a few years, they've been extremely happy, I would say.
When we do this monovision, with the passage of time, the eye in which you have overcorrected becomes the distance eye.
Correct. That's why they still can read, and they might just need, after a couple of years, your reading glasses. That's right.
Yeah, I think this has covered this well. Swapnesh?
Yeah. So then the most common complaint from the patient, post LASIK glare, how to manage these patients.
So we'll ask Berger to start off.
What do you define by glare?
Patients who are
so
Berger, what is the patient complaining about?
Night driving, all the evening problems, the lights forming a starburst, everything. But basically what you tried to say initially at the beginning, the pupil thing and all that, but in spite of all that, if patient develops these, are there any medicines or some simple ways to help them?
Boss, everything will be temporary. I mean, we've all used dilute pilocarpine. But the patient gets very pissed off here to have to put in drops, especially if it's a young patient. And time is a very good balm for everything, because with time, eventually, whatever the patient is seeing becomes his reality. So it involves a lot of hand holding. I don't think there's any physical thing you can do, of course. Do your topography, see whether you've decentered the treatment. If it's decentered, you can then recenter it with a TopoLink LASIK, but otherwise precious little you can do.
Anything to add, Nitin?
Pre-op counseling, very, very important. Tell them that they are going to expect this to some extent. Post-operatively, one has to reassure, and if the patient wants to do a night driving, a simple trick what we use is tell them to use, put on the cabin light in the car. So as long as the cabin light is on, these patients do not experience that much of the night vision problem while driving.
Himanshu, anything?
Brimonidine?
Yes.
Brimonidine?
Yeah, alpha-GAN.
The question is the same as multifocal.
Correct.
The problems of halos. If you look at Berger, is already enlightened. So if somebody sees a halo around Berger, they know they're seeing the right person.
Okay. So I think this covers this. Swapnesh, you can.
So Dr. Firoz Patel sir wants to make a comment.
Yeah.
I just wanted to mention that.
Hi, Firoz.
Yep. That sporting people very often have these issues about glare, etc., especially when they are playing billiards and snooker. And alpha-GAN Z is very effective, an hour or so before they play any cue sport, for example, to shut the pupil down just a tiny bit to avoid that glare issues when they are playing.
Yeah, that's correct.
Thank you. Yeah, Firoz. Yeah, Swapnesh, next.
What if the patient falls asleep while playing snooker?
Okay, Swapnesh, what is next?
So the next LASIK versus PRK we have already answered.
Correct.
Then LASIK as a secondary procedure to correct the refractive error post cataract surgery. Your take on that?
Yeah, so this is excellent mode if you've got some cylinder left, some defocused left, and especially in multifocal IOLs, because they are the ones who, even with a small amount of residual sphere, small amount of residual cylinder, they complain a lot and they have a lot of visual disturbances. In fact, you'll be surprised. There's the surgeon with one of the largest refractive practices in India. And when I was in his OT once, and when he does a multifocal, in fact, he takes a flap first. He takes a keratome flap in both the eyes, puts the multifocal, because invariably you never get 0-0. And then he just does a little touch up after a few weeks, and he has a very happy patient. So let's take everybody's opinion on this cataract, post-cataract LASIK. Berger?
That whoever this surgeon is seems to have a singular lack of confidence in his in his cataract surgeries. Yeah, we used to call this bioptics.
Yeah.
In days gone by, when
Yeah.
we treat the extreme myopes, and we do a bit of the lens exchange and a bit of the LASIK, and we do the flaps beforehand. But Shashi, I'm interested to know your opinion here. Now, if there's a patient who's had LASIK done and the patient comes in for cataract, a multifocal is not our
No.
first. No.
Baja, the question is opposite.
Hold on.
Oh, okay.
Hold on. So when we face this, a patient has had LASIK and he's come to us for a cataract.
Yeah.
Our first choice of lens is not a multifocal, right?
Correct.
Okay. So why should we be doing a LASIK on a patient who's already had a multifocal?
Very good way of thinking. Very good way of thinking. Yep.
You know, so in the few cases which I have done, and I remain open to correction, the results have been shit.
Okay.
In multifocals who have got a correction with LASIK for a residual. And these patients, mind you, will be the ones who have the residual cylinders more than the residual spheres.
Correct.
So unless your cylinder is corrected phenomenally with your LASIK, you're going to land up in more of a problem. Now, this is completely different for a monofocal lens, where he will have a brilliant result with LASIK for a dioptric surprise. But I would exercise caution when you're doing a LASIK on a multifocal patient.
Perfect. Very perfect. Very well taken. Anything to add, Nitin?
Entirely agree with what Barjor said. For a monofocal, definitely it works very well, but for a multifocal, one has to be careful.
Okay. Himanshu, anything to add? Hello?
Absolutely difficult scenario because already they were unhappy.
Sir.
And if you
sir,
do
can you repeat, sir?
Yeah, sorry. Can you hear me now?
Yes.
Yeah.
Okay. So they are already unhappy with your multifocal, unfortunately, whatever you did. And you have a residual. And on top of which you induce more aberrations, you can land up into deep trouble. Yeah.
Okay. So this is good covered. Swapnesh, what is next?
So side by side, there is a question from Dr. Kapoor, but how soon can one retreat under correction?
Retreat. How soon do you take up the regression?
Yes.
Under correction.
Under correction.
Yes.
Yeah. So I think this is just as we said, under correction you diagnose initially, you don't have to wait, and there's no need to wait. According to me, you can take it up. Baja, let's take just one.
Yeah, absolutely.
Yeah, so I think that's okay.
You can take it up as soon as it's seen virtually.
Virtually. Okay, you can go to the next.
But let me caveat that.
Yes.
Now, if the patient is really pissed off, if the patient has to leave back abroad and stuff like that, yes, you are justified in doing it very soon, say 5 days, a week later. But if the patient is with you at home, I think you should temporize a bit. You don't know where it's going to go. There may be corneal edema. There may be a whole load of other stuff going on. So let the dust settle a bit. Let the number settle a bit. Do it a month later. It's not a big deal.
Yes.
Don't appear super worried in front of the patient. That is my take home to everybody. Because your fear, worry, whatever will rub off in an instant onto the patient. So tell the patient it's fine. Yeah, I'll do another thing in a month. Don't worry, come back.
Yeah. So as Baja said initially, even then, you shouldn't be deciding that it's under correction in the immediate week, because as he said, corneal edema, reaction, so you should take your time. And once you've decided in a few weeks they need it, you can go ahead. I think that covers that. Swapnesh, what is next?
Yeah, our past president, Honorable Past President Dr. Usha Johri is asking a question regarding role of neuroplasticity in post-LASIK glare. If anybody has
in post-LASIK
glare, in patients who have post-LASIK glare, if anybody has a experience with that?
I don't have any experience. Roger?
You know, patients ask me that, doctor, will these halos remain? And I mean, will they be there forever? My answer to them is, to a certain extent, yes, they will. But given the passage of time, you're not going to see them unless you look for them.
Excellent. That, I think, is a good way of putting it.
You know?
Okay, Swapnesh, next.
So Himanshu sir wants to make a comment.
Himanshu.
So, Shashi, the bigger problem is when each of these people become a messiah, they keep comparing between the two eyes. I'll go back to the previous question. One eye is always going to be a little undercorrected because they don't behave the same way. The bigger problem is when they start complaining that I'm seeing better from one eye than the other eye. That is a bigger irritant in life than anything else.
Yeah, sure. That they have to be counseled for that. Okay, Swapnesh.
Yeah, next question. Yeah, so our routine questions. Pediatric LASIK for amblyopia correction. Is it in or out?
Okay, Baja.
I have done a handful of cases. You're not going to make them 6/6 again, but you're going to retrieve some degree of neural remodeling in these children who otherwise would have been densely amblyopic. But I do it before they were 6, 7 years of age.
Okay. Himanshu?
I haven't any experience in pediatrics.
Nitin?
Hardly 2 or 3 cases, but
okay.
Yeah,
Okay, Swapnesh?
Yeah. So patient has come for LASIK evaluation, has a blue dot cataract. Will you proceed? What would be your management?
Yeah. So, Nitin?
Document it. Explain to the patient that he's got a blue dot cataract. Take an anterior segment photograph so that tomorrow you pulled up that you caused the cataract. And I think you can go ahead with the LASIK.
I think there's nothing in this question. That would be, I think, everybody's view. What's next, Swapnesh?
Yeah, patient who has come for LASIK evaluation is already on polycystic ovarian disease treatment. So she's undergoing a hormonal therapy. Yeah. So how would be your counseling?
Contraindicated. Yes. Himanshu, what would you say?
I tell you right now, if I see cross-section, quite a few young females who come between the age of 20 and 30, 35 are on, I have POCD if you ask the question. Quite a few of them are on hormonal treatment. It wouldn't be a great contraindication unless the sugars are fluctuating and or their number has fluctuated big time in the past year or so.
Okay, anything to add, Baja?
I wouldn't do it.
Okay.
Because the cornea is going to change shape with their hormones bouncing everywhere. And they will hold the gun to your head when your initial correction is very good. But once they are off therapy and the cornea then goes back to its normal shape, so there will be some change. If you want to go ahead, go and do it, but tell them.
Counsel them.
Yeah, counsel them.
That's good. Yeah.
So that comes a corollary.
Okay.
How many of us really check with all these women in this young age group regarding their cycles, whether they are taking medications for POCD, are they on OCPs?
No, I don't check, Himanshu, to be very frank. But one of the questions in my questionnaire is whether they are on oral birth control pills, which are estrogen. You know, so I do tell them, and certainly, you know, funnily enough, I have diagnosed many pregnant women before they knew they were pregnant. Because their history, their history was that their contact lenses kept on falling off and not fitting suddenly. You know, so my first question is, are you pregnant? And they're, no, doc, no. And then they come a year later, that, how did you know I was pregnant?
That's a nice one. Okay.
Yeah.
So we have got this. Swapnesh, what's next?
Yeah. Is having a pingula in the eye a contraindication for LASIK? And should the surface procedure be advised in these patients?
I have done small pinguiculas, and the suction rings, at least the modern ones, have not given me any trouble, you know, small ones. But what is, Nitin, anything on this?
No, if it's a small pingicula, we can go ahead. It's much simpler to do a femtoflap with the pingicula because your the suction ring doesn't cover the pingicula. The most important thing is with the microkeratome ring, you may have a pseudosuction. You may lose suction while making the flap. So one has to be careful about that.
Yeah.
But yes, if you can achieve a good suction and there's no harm in going ahead.
Bhaja, anything to add?
No, I go ahead quite happily.
Okay. Swapnesh, sorry.
Different issue if it's a pterygium, mind you.
We can take that also.
To do if it's a pterygium?
Then you do a surface ablation, or whatever doesn't involve a suction device.
Yeah. Okay, Swapnesh, next.
Yeah. Is family history of glaucoma a relative contraindication? Is it compulsory to include it in the pre-LASIK evaluation?
Himanshu, what would you say to this?
Relative contraindication, yes, but not necessarily that they would be having glaucoma. So you would.
No. What relative contraindication? What will you do it or won't do it? If there's a family history, they don't have glaucoma. There's a family history of glaucoma.
Yeah, there is a family history. If there is a strong history, you're not going to do it. But if it's not a very, very dangerous way of operating, you know the history, then you would do in certain cases because quite often you may not be sure. But if you are sure that family history is strong, you would be very careful in telling them to do LASIK surgery.
Why, Himanshu?
Because your pressures post-operatively. That's why I'm saying relative contraindication, because you'll tell them that your pressures will be inappropriate later on.
So they're going to get, if they're going to get glaucoma, they'll get it.
Yes.
How is LASIK going to change it either way?
It is not an absolute contraindication.
I think I would go with that, what Bhaja says. You know, we know that the pressures are going to be low and we'll compensate for that. Nitin, anything to add for that?
As long as the patient is not a steroid responder, I don't think there is a contraindication because one can go ahead and do a LASIK. One needs to see what is a post-LASIK corneal thickness and then have the IOP corrected. And every time check out the corrected IOP and not the IOP which is made.
And maybe somebody might say, you know, that I'll do a PRK because the suction ring, you know, pressure should not be there in case, you know, this is a latent glaucoma or something. But we are not saying the patient has glaucoma, just family history. So I think that is also irrelevant. Yeah, Swapnesh, what's next?
Yeah, a patient has a high cylinder in one eye and in other eye there is no refractive error and the topo is normal. Can I go ahead with the LASIK for that particular eye?
So see, this you are just saying that topo is normal, you know, and cylinder is a cylinder, low, medium or high. So there's no reason to sort of think anyway otherwise. Nitin, would you have anything else to say?
If as long as the topo is normal, there's absolutely no contraindication. One can go ahead with the LASIK.
Bhaja, anything?
In fact, it is the indication to do LASIK.
Yes, yeah, correct. So I think this is okay. Yeah. Next, Swapnesh.
Now the next questions are related to femto procedures mostly.
Yeah.
Have the panelists faced any of this, and how did you manage the particular scenarios, and why did it happen? Gas bubble, opaque bubble layer, vertical gas breakthrough, central toxic keratopathy. So,
okay, so let's give one. Let's let them take one. Nitin, you want to take gas bubble in the AC?
Yeah, the gas bubble in the AC is seen. I've seen it at least in about 2 or 3 of my femto LASIK cases. Basically, this usually happens when your venting canal is opening somewhere near the Schlemm's canal. So that is the time when the OBL, which is coming out from the venting canal, enters into the AC. It's no big deal. The only problem is the eye tracker will not work if there is an air bubble in the anterior chamber. So one needs to do not open the flap. The first and the foremost is do not lift the flap. Make the patient wait maybe for about an hour and a half. And after that, in all probabilities, you will see the air bubble getting absorbed and one can go ahead and do. As long as the air bubble is not in the center blocking the pupillary aperture, there is no harm doing it.
Okay, thank you. Bhaja, would you like to take opaque bubble layer?
No, what do you mean by everybody has some opaque bubble layer?
Opaque, some. If it is excess,
then I'd wait,
yeah.
And then go back and do it.
Do it after some time. Himanshu, vertical gas breakthrough?
Well, that's the problem which we face. Fortunately, in my machine, which is there, the Lens X, I haven't had that. I would want Nitin to give me that.
CTK? No. Then would you like to take CTK, Himanshu? Central toxic keratopathy?
That's the area where we'll have to get on with the steroid, whether to use steroid and how much and how long will you have to take steroids. That's the answer to that. The bottom line is diagnosing it
Okay.
time and
diagnosing it. Correct. Bhaja, would you like to add something on CTK?
No, boss, I've not seen it.
Correct.
I don't know.
Okay, Swapnesh, this is covered. What's next?
Yeah. So we have finished our quota of questions.
I
just
saw.
taking.
Sorry, Swapnesh.
Yes,
I
sir.
saw a question in the chat, but I can't
yeah.
find it anymore.
Then
That what if inadvertently you are doing a LASIK and a PRK has been entered into the machine?
Yes.
Would it make any difference to your final outcome? I think if it did, it would be really minimal.
Okay.
Very minimal. The normograms are virtually, the ablation profiles are virtually the same.
Sure. So Dr. Maru has asked a question regarding some clarity about presbyopic LASIK. He has asked what is done for presbyopic LASIK. Dr. Sanjeev Maru.
So let's start with Bhaja. What is your opinion on presbyopic LASIK?
You know, my opinion is an old opinion. We were amongst the first to do it in 1995. We did about 25 cases and none of them worked. But much water has passed under the bridge since then. Historically, presby LASIK is an unpredictable beast. But some people who've had it done on themselves have said it's worked for them. I really can't give an honest opinion.
Himanshu?
I'm all for monovision. It could be a monofocal lens and or LASIK. Anybody above 40 plus, I'm absolutely for monovision rather than presby LASIK.
Okay, Nitin?
Monovision with a Q value adjustment. Try to make the cornea hyperpolate in the eye which you're undercorrecting for myopia or overcorrecting for hyperopia. So if you make the cornea hyperpolate, you will increase the depth of focus and these patients are experiencing.
So I think it is unpredictable, as Bhaja said. We have to move with caution in this area because of the uncertain nature of its progression. What next, Swapnesh?
Dr. Vitthal Sata from Pune is asking a question: how to identify epithelial side and the stromal side if not marked? Obviously, in the case of pre-flap, probably.
So epithelial side is shinier and the stromal side is duller. You can make a scratch and see a fluorescein and all in a very difficult situation. But is there any other hint?
Yeah.
Sorry. Is one thing that can help you in case you're, as long as you have a sterile fluorescein strip, you can use fluorescein.
Yeah. Bhaja, you were saying something?
Yeah. When you get a free flap, your flap margin is not going to be perfectly circular. There are going to be some zigzag sort of in a very microscopic way, some slight zigzag sort of indentation somewhere here where the hinge was supposed to be. Now, if your stromal side is up, hello?
Yeah, we can hear you.
Yeah, if the stromal side is up, that jigsaw won't fit.
Okay.
Where the hinge is and where the flap is, that it will be, you just won't be able to get a fit. And
so that is another way of,
Yeah, absolutely. So if you flip it, then the peninsulas in one will mix with the isthmus in the other, and it will fit. So, and I'm talking about, I had this before I was fanatical about marking. Then I left marking because I found that I got a huge amount of sands, and I found it was due to the pen.
Yeah.
So I stopped marking, but I used to stress that marking and applanation were two of the most
Two.
important things to do in LASIK.
Correct. Yeah, Swapnesh. Next.
Yeah. Dr. Nittal Maniar,
Yeah.
probably is a question for Dr. Himanshu sir. In a routine LASIK in presbyo, how much do you adjust for presbyopia?
Yeah, depending on the age group, but you won't stretch beyond 1.5 between the two eyes.
Within same? Okay.
Agree with
that. Yeah, Swapnesh.
Yes, sir. So I think we have covered most of the questions. One last question I'll take from Dr. Relan. Any special precautions to be taken while doing a photoablative procedure post-COVID? What are the chances of virus being airborne due to the plume? Hepatitis B virus has been found in the LASIK plume.
Yeah. So I think, first of all, I heard about this question being asked a week back. And first of all, the plume, at that point, someone said the tears have got the virus, and the tears come up in the plume during LASIK. First of all, the plume is made up of stromal, ablation matter. And I don't think there's any evidence of there being, as of now, the virus have been isolated in the stroma of the cornea. And let's take it to the house. Berger, anything?
It's all hypothetical, Sashi. How can we
Correct.
say anything about it today?
Correct.
Yeah, of course it was there. In days gone by, the high volume PRK surgeons used to get lung problems. I know there was a surgeon, if you remember his name, Tennant, some fellow called Tennant. He made a lens also, an IOL. He died of stuff that he had inhaled for about 5-7 years.
Okay.
Yeah, he got some
So,
cancer or something
Nitin,
like
anything?
It's like Bajor said, it is hypothetical. One has to wait and watch.
Watch.
My main thing: are we going to get the cases for doing refractive
Correct.
surgery for this lump? That is the main.
Himanshu,
That's the main
anything?
question.
Yeah, Himanshu, anything to add? This is the last question.
No, thank you.
Thank you. Thank you, Swapnesh. Thank you, Berger, Nitin,
Thank you.
Himanshu.
Thank you.
We had a
Pritam,
great time. Pritam
Pritam
sir,
sir as
thank
well.
you for a beautiful,
Thank you.
Only addition that I would make, Shashi,
Yep.
is that for the young guys, don't get scared listening to all these complications. It's not that bad. It's pretty simple and good surgery. Very rewarding when patients are happy. And that's why we're still continuing with the surgery.
And rewarding even when they are not happy. Yeah.
Swapnesh,
And
thank you. Are
forgiving
we
surgery.
switching off?
Very forgiving surgery.
I'll just conclude by
Finish?
saying that I'll just make a conclusion, sir.
Yes.
It is a fantastic way to conduct the CME rather than having slides and didactic talks. Question and answer makes it really interesting. I think a lot of the questions also. Oh, Sapnesh is offering me some cake, is it?
We're all having it. This is a virtual cake.
So I think it was a great way. Probably this will we'll do it more often in the seminars which are to follow. And so just for all our viewers, the next webinar is going to be on Saturday, and we are going to talk about coronavirus itself, the pandemic, and a lot of important things, unanswered questions regarding the corona pandemic. And we are having one of the Kasturba Hospital Dr. Om Srivastava, who's going to be there. Then we have a chest physician, very reputed from Lilavati, Dr. Prabhu Desai, and we have our own Dr. Lahane sir. So, these are the three people who are going to speak on the relevant aspects of corona, more related to ophthalmology.